Everyone, and good afternoon. Thank you for joining today's webinar organized by EURO-NMD in collaboration with the European Academy of Neurology and ERN-R&D for rare neurological diseases. Today, we are pleased to launch our new webinar series on neuromuscular junction disorders with the first episode presented by Dr. Lorenzo Maggi and Lutgarde Allard. So it's how to evaluate patients with myasthenia gravis. So Dr. Lorenzo Maggi is from the Fondazione IRCCS Istituto Neurologico Carlo Besta in Milan. And Lutgarde is representing the European Myasthenia Gravis Association, which is the president of this association. So just to remind you that today's webinar is recorded, and at the end of the session, you will have the opportunity to ask your question to Dr. Lorenzo Maggi and Lutgarde Allard. So thank you very much for being with us today. And now we have the pleasure to give the floor to Dr. Lorenzo Maggi and Lutgarde Allard. Thank you very much.
Thank you very much, Elizabeth, and good afternoon, everyone. Thanks for being here, although virtually, not in person. I would like to thank, of course, the EURO-NMD for the kind invitation, but also for all this webinar focused on myasthenia gravis. It's also a pleasure for me to be here today to present this topic on myasthenia gravis together with a patient representative, because it could be a bit embarrassing to talk about the patient evaluation, the patient point of view, but without having any patient. And so I think that it is very, very relevant to have directly the patient perspective and point of view. And okay, so I will talk to you about how to evaluate patient with myasthenia gravis. So these are my disclosure. And I start this just with this figure representing the mortality rate of myasthenia gravis over the time. And you, of course, may see that the mortality rate has been clearly reduced over the time across the decades, thanks to the introduction of the traditional treatments for myasthenia gravis, thanks to the introduction of assisted ventilation. And of course, similarly, also we observed an improvement of the overall management of patients with myasthenia gravis and their quality of life. But I think, and also I would ask this point to Lut, that there is still a relatively large amount of patients with unmet needs, mainly in relation to the side effects of concomitant therapies, but also due to the unsatisfactory control of symptoms. So with really huge impact on the daily activities. And now, thanks to the introduction of innovative therapies, I think that we should be more granular in our patients' evaluation. We should try to improve our skills in the patient evaluation. And so now there is a new interest given to the tools to assess and to evaluate patient changes over the time. And so why do we need to evaluate MG patient in clinical practice? Well, as I have just mentioned, just because we need to evaluate and to quantify the disease severity, we need also to identify the non-responder patients and also to help the management of the disease. We needed to discriminate the fluctuation from the relapses, the true clinical relapses. We needed to monitor and quantify the disease changes over the time, regardless of the ongoing treatments. But of course, we need also to test the response to specific treatment. We need also to use specific tools to evaluate MG patient, because this is mandatory. For example, in Italy, it is mandatory to use specific tools just to have the permission to use the new innovative therapies. So we are just shifting from clinical tools that were just used and limited in clinical trials to their use, their application in the routine clinical practice. And there are, however, some issues, and we know that myasthenia gravis has been traditionally defined as a chronic disease with clinical relapses. However, a long period of disease stability or pharmacological remission may be observed. The MG natural history has not been completely clarified yet, in particular in terms of risk and time to relapse. There is a huge inter- and intra-individual heterogeneity, together with fluctuation in skeletal muscle weakness. This could make quite challenging the prediction of the clinical course of the disease. On the other side, the routine clinical evaluation just allows an isolated assessment with risk of underestimation of the disease burden and severity of the disease. And also there are confounding factors, especially in older patients and in case of comorbidities. Here I have just mentioned two initial efforts to try to classify the MG clinical symptom and signs. They have been performed many years ago, reported by Osserman, the Osserman classification in 1958, and a few years later, the Osterhuis classification in 1964. They were just based on the distribution of the muscle weakness and fatigability, so classifying the patient in 4 subgroups: ocular, generalized, bulbar, and respiratory myasthenia gravis. We know now that there are many different classifications. Probably the best one is the clinical biological classification, so putting together clinical features and the antibody status. And we know that, for example, some of these subgroups have specifically prognostic features. For example, we know that patient with type beta hemoma or the antibodies to mask as a sort of more severe disease compared to other myasthenia gravis subgroups. And the Myasthenia Gravis Foundation of America in 2000 also provided this sort of update of the Osserman classification, which is somehow more comprehensive. It has been used in many different studies, but it is still highly subjective to the clinical opinion. But in the same study, the MGFA, the Myasthenia Gravis Foundation of America, also suggested to use the MGFA PIS, the post-intervention status, to evaluate the clinical condition of MG patient at any time after starting a treatment. The MGFA PIS has been the most frequently used MG outcome measure in the past, but in most of the studies, the authors just consider MGFA PIS at the last follow-up visit without considering any modification of the disease severity over the time. So as a dynamic process, as it is in the real world. And also the same paper published on Neurology in 2000 also provided initial goals for the treatment. Again, in agreement with the PIS, the goals for the treatment were established as the complete stable remission, the pharmacological remission, and the minimal manifestation status. This was also confirmed in the International Consensus Guidance for the Management of Myasthenia Gravis, published in 2016. However, the definition of other subgroup has improved and changed and worsened still represent a gray area, because it is very, very difficult to discriminate these 3 different subgroups. Overall, I think that a different physician may have different perception and definition of severity, also considering the tools that I have just mentioned to you. And what about other clinical outcome measures in myasthenia gravis? We have many tools that test different aspects of the disease. There are patient-reported versus physician-scored outcome measures. There is a sort of heterogeneous adoption all over the world. They have been considered as a mandatory in clinical trials, but they are relatively poorly or inconsistently used in the clinical practice. Most of the scores just focus on clinical manifestation, but without considering or their impact on quality of life. That is still not completely clarified. It is still not clear how to integrate the different scores and translate them into a clinical decision, for example, regarding changing a therapy or increasing or reducing the dosage of a treatment. Also, the patient adaptation to their status, because it's a chronic disease, sometimes make them underestimate their disease severity. And also physicians often just focus on physical symptoms and underestimate the overall disease burden. That, of course, impact other aspects of every patient, so the quality of life, the psychological aspects, and so on. So now let's move to the physician outcome measure. The main physician outcome measure, physician-attested outcome measure is the QMG. that has been published again in the same paper in 2000 on neurology. It includes 13 physician-evaluated items. It is standardized and reproducible. It is very sensitive to clinical changes over the time, and it has been considered the gold standard in many studies for ages, I can say. But it is time-consuming, taking at least 20 minutes. It requires training and also specific equipment as the spirometer, the dynamometer, which may be not available in the outpatient clinic. The other physician-reported outcome measure is the EuMGA composite that has been proposed later compared to the QMG. It's a mixed scale intended to select the best items from a range of scales available at that time. It includes both patient-reported outcome measure, in particular the bulbar and the respiratory items are just patient-reported outcome measure in this scale, and also physician-evaluated items. The items are weighted, so the highest score for the bulbar and respiratory items has clearly a higher weight on the overall score compared to the ocular items. And it is much more focused on weakness than fatigability, and this is the opposite for the QMG. It is faster and easier to administer than the QMG. It also included the patient experience, thanks to the introduction of the subjective symptoms. It has been validated and used in both clinics and in pharmacological trials. There is still some subjectivity, in particular in relation to the evaluation of the strength of different muscles. But these are the main challenges for QMG and then EuMGA composite. For the QMG, the arm, leg, and neck fatigability tests are insufficiently standardized. There is also lack of clarity about the number of the force and vital capacity attempts, normative data, and common confounding situation. There is no standard test and rest and testing sequence for the hand grip, and also the original instruction assumed that the right hand is the dominant hand in all the patient, but this is not true, of course. And there is no standardized speed for the single breath count, and also lack of clarity about the periodistic mean timing. Regarding the EuMGA composite, there are some uncertainty about the positioning during the assessment of specific muscles, and also about the interpretation of weakness grading, which is highly variable. It is very operator dependent. But now let's move to the patient perspective. Patient, of course, can be expert on their experiences, and this can facilitate their involvement in clinical decision making. Now, with the introduction of the innovative therapies, where we know that there is no evidence from literature of superiority of one specific drug on the other innovative therapies, the patient's choice is still very, very relevant in the treatment choice. And also the EuMGA symptoms fluctuate, so the objective assessment may not necessarily reflect the patient disease burden. And also, I think that the patient in the future will be even more involved in the treatment choice. The EuMGA-DL is the main patient-reported outcome measure. Is a 8-item patient-reported scale assessing the daily activity, so it is quite different from QMG and the EuMGA composite. It is largely used. It does not need any specific training. It's very easy and fast to perform. It takes around 2 or 3 minutes. A 2-point improvement in the EuMGA-DL indicates a clinical improvement or a meaningful improvement. Also, the scale correlates with the other available assessments, so the QMG, the EuMGA quality of life 15, and the EuMGA composite. It may be used even remotely. And the disadvantage is that not include axial items, and also the evaluation, for example, of the tongue, and not include weighted items. In any case, all the clinical trials testing innovative therapies considered the EuMGA-DL as the primary endpoint. So the EuMGA-DL is now the main outcome measure that should be used in clinical practice for myasthenia gravis, even more important than the EuMGA. And also there is a good concordance between patients and neurologists when assessing the EuMGA-DL. You may see on the left that there are just a few outliers, and in this figure on the right, you may see that there is also good concordance according to the disease severity, except for more severe form of the disease, for example, the NGFA class 4A and 4B, where in the physician evaluation, there is a sort of overestimation compared to the patient evaluation. So there are some discrepancies, but just in patients with a higher disease severity. Then G quality of life 15 is a patient-reported outcome measure focused on the quality of life, in particular on the assessment of physical, psychological, and social domains. This scale showed a very good correlation with NGADL and NMJ composite. There are still some unclear instruction regarding the recall period, but usually there is a good agreement that it should refer to the previous 4 weeks. And also there are unclear instructions about the scoring of specific item when the subject cannot decide between 2 different grades. So it is not clear if he or she should decide the worse option or the better option. And now there are new goals for the treatment beyond the MGFA post-intervention status, and all of them substantially are patient-reported outcome. For example, the minimal symptom expression, which is a very good goal for treatment. It is initially derived from data from the REGAIN clinical trial, and it has been defined as a total MG-ADL score between 0 and 1, or MG quality of life 15, the revised scale, a score ranging from 0 to 3. And also a further concept has been introduced as the patient acceptable symptom statement, the PASS, which includes this very simple question that should be asked to the patients, but also established thresholds for QNG, MGDL, MG composite, and even MG quality of life 15. And patient below this threshold could be considered as patient with a good control of disease activity. The MG, DIS is a patient-reported outcome measure focused on disability. Myasthenia gravis has been specifically designed for myasthenia gravis. It includes 4 domains on ocular, generalized, bulbar, and respiratory symptoms. It refers to the last 30 days, but to be honest, I think that it is not much frequently used in the clinical practice. And the same also for the MG impairment index. It includes 6 items tested by the physician and 22 as patient-reported items. It takes around 10 minutes. It's a good scale, again, but I think that the use in the clinical practice is quite rare and in any case quite heterogeneous. What about the suggestion from the international and national recommendation for the outcome measure? Well, the outcome measure has substantially not been mentioned in the international consensus published in 2016 and in the update published in 2021, but quantitative score and in particular the MGADL are somehow suggested and recommended in different national guidelines. For example, the Italian guidelines, the German ones, the guidelines from Belgium, and even the more recent guidelines from UK. So which tools or outcome measures should be used in clinical practice to assess patients? Well, I think that the first option should be MGADL, that should be always performed. It is also useful because it could be performed remotely, so for example by phone. And then the QNG and also the MG quality of life 15. QNG is recommended in case of worsening detected, for example, by MGADL. And of course, when it is required, when you have to define the response to a specific treatment. And also, I think that patients plus the physician impression are still very relevant. They are not quantitative, but they are still relevant. The guidelines for the management of myasthenic syndromes are published by the German network. I think that represented a milestone in the field, in particular because the classification of myasthenia gravis should be no longer static, so nothing written in the stone, but It requires review and continuous monitoring, and also must assess continuously the disease activity, or at least regularly, through the assessment of the disease severity, the response to treatment, the fluctuation, and the time course. Also, these guidelines establish a clear differentiation between mild and moderate disease and highly active myasthenia gravis. Also, they provided some specific threshold for MGDL and QNG to define the improvement. And but in this regard, as I show you here, it is very difficult now to define clearly the response to treatment. There is no international agreement. We may say that a reduction of 2 points with MGDL or a reduction of 3 points with QNG could be enough to define that patient as a responder. But in some studies, the author considered higher threshold, for example, improvement of 3 points with the MGDL and at least 5 points with the QNG. In any case, to define response to treatment, you should not rely on a single scale. Ambiguous results should be always retested in the short period. A single score is not relevant, but it should be considered the trend over the time and the maintenance of the benefit. And also, it is challenging when results among MGDL and QNG are discrepant. And I do not have a specific answer for this. But we should try also to go beyond the usual scales, because, for example, around 40% of the patients with myasthenia gravis have depression, and around 50% of the patients with myasthenia gravis have anxiety. And if you see this data from the My Real World MG, we may see that people diagnosed with myasthenia gravis, compared to the general population, have almost 3 times more sick leave, are 3 times more unable to work at all, and they twice more need medical care, and also they need 5 times more a caregiver to help them in their daily activities. So this reveals a very deep impact on the daily activities, on the daily life of patients with myasthenia gravis. Of course, I think that Lut will probably will focus better on this point, but the clinical scales that we use now are not enough. They clearly are not able to reflect the overall impact of the disease in patients with myasthenia gravis. So this is just my last slides. They are my conclusions. Myasthenia gravis is a fluctuating disease. The clinical status can change several times, even in a short time interval. This is a very exciting phase, thanks to the introduction of new treatments, with the MG world becoming more and more complex, but also I think that we need to better evaluate and understand the disease changes over the time. The patient-reported outcome measure have an important role in disease monitoring and the response to treatment, and they also able to quantify the MG disease burden probably much better than the objective measures. Of course, the perfect tool to evaluate patient does not exist, but a combination of tool, patient-reported plus physician-scored measure is highly recommended. The available tools are probably not completely appropriate for specific subgroup of patients, for example, patients in the pediatric age and even older patients. It is also somehow difficult to establish when patients should be evaluated or re-evaluated. And this is just my last sentence. So a clinical meaningful improvement does not necessarily correspond to an improved outcome. We may see patients with an MGDL improving from 19 to 11, but this does not mean that the patient has a satisfactory control of the disease. So I would like just to thank all the people working with me, and thank you, all of you that are in the audience. Thanks so much. Thank you.
Thank you, Dr. Maggi. And thank you to the EURO-NMD for inviting me and just to give the vision of the patients. To be honest, we started a few years ago being part also of the EURO-NMD muscular junction disease working group. I'm very happy to be there, and I'm even more happy just to follow you up, Dr. Maggi, because you told so much, and I want to thank you for your commitment to our community, because most of the time we met each other at the different congresses. So I know you are very committed and you know what you are speaking about it. So I had the opportunity to start to work on the patient journey on Myasthenia Gravis a few years ago. Elizabeth, first one, please. Yes, thank you. We worked on it with a few patients and we started to think about what was our journey. And for most of them, independent from which country we came, we all had the same issues. First of all, as young women, we had the problem when we saw first our general practice of the first specialist we go to. It's always the same. You are young, you're a woman, you have the burnout, you have too much to do, and it's always the same. It's mental. Be aware of that. So you better go to a psychiatrist instead of a neurologist or whatever. At the end of a long journey, more than a year, we finally find someone who believes in us. And that was our first step, even for us, recognizing our first symptoms. In the beginning, you're thinking, oh, it's because I'm nervous. Or during my pregnancy, I thought, oh, it's because I'm pregnant. It's always something, but you never think about a rare disease. So that was the first thing, recognize your first symptoms. And as Dr. Maggi explained this, it's very variable, fluctuating throughout the day or several days. And it can just pop up without any previous warning. So be aware, but try to recognize them. Because they are so variable, the symptoms can be difficult to interpret and the link to the no disease. From problems with simple movements such as combing your hair, difficulty walking, chewing or swallowing, as well as articulating words when speaking for long periods, even for short periods when you are tired, the double vision, the droopy eyelids, whatever. Some of us just think, I'm tired, it will pass, and the days pass too. Then we are getting to the right diagnosis was step 2, and that was also not easy. A general practitioner has to ask himself 3 simple questions. Could this be a rare disease? Could this be a neurological disease? Could this be Myasthenia Gravis? But as I said in one of the first congresses I collaborate and participate in, we are not getting sick or ill by the book. Some of the symptoms are not even written in the study books of doctors. And one of them is incontinence. With some people, it starts with a kind of incontinence, and you can't say to a woman after she delivered for 10 years before, it's due to the fact that you delivered, but not 10 years later. So those are always the difficulties. I know not all symptoms are recognized for the moment because some of us are speaking of brain fog. It's recognized after COVID, but with MG, it's still difficult. So those are also the difficulties to get a right diagnosis. And it's not only to have the right diagnosis and find a doctor who believes in you, but it's also to find the right doctor. And that's the difference with most of patients who have cancer. Those are supported by a multidisciplinary team. And that's something that is not always the fact in MG. So to be honest, that should be one of the things that should change for all MG patients if they have the need. So one of the unmet needs is the support of a multidisciplinary team. So finding the right diagnosis and then be referred to the right doctor for the following up. And that was for us the 3rd step. the following up of the disease. MG patients should mainly be followed by a specialist. That's something we all agree on. We can't ask general practitioners that they know everything about all diseases, especially rare diseases, because there are more than 6,000 of them. So it's important to establish a good cooperation, communication between the general practitioner, the specialist, and the patient. And that's something that doesn't work very well. And I think it's not only in my country, it's not only in Italy, but in the most of the European countries, unfortunately. So finding a good doctor, or at least finding a neuromuscular center where you are followed by experts. Most of the time, when you find a good doctor over there, a good specialist, you have also the support of the other team members. And so you get a better multidisciplinary support, which is very important for better care. And then step 4, that's the other one. And Dr. Maggi spoke about the new treatments, but sometimes it's even difficult to find a right treatment, and including psychosocial support, because not all patients react in the same way to the same classical treatments. Some are refractive, which means that they don't react at all and still have a very severe MG. So, to be honest, it's always difficult, and Myasthenia Gravis is a never-ending story. So that's something that we all know, because most of us are living with MG, and we don't need to speak a lot about our illness because we do understand each other without words. If some of us have problems with eating, nobody will say anything about it. And I remember in the first summit we had last year in Amsterdam, there was one of the young patients who said, "It has been a long time, but this weekend I just felt normal," because she was in a group of all patients and nobody said anything about the disease. Nobody needs to say anything. Everybody felt at home, everybody felt at ease, and if there was something, we could help each other. So just feeling normal, that's also important for our patients. Next to getting the right treatment and having other psychologists as a support and a social support, because those are things which are very important. As Dr. Maggi said, also, a lot of MG patients can't work. A lot of them get isolated, and especially when they are young, that's really, really an issue. So for the 5th step, getting the general support, it's also important. Patients with a heavy burden that affects all aspects of their life. They may have to give up their work, as do their careers, or their carers too, who are usually parents or close relatives, resulting in greater financial burden. Social support may be needed, and patients need to be informed about existing networks available in their countries. That's one of the issues we have in all countries. People not always know where to go to, where they can find support, don't know always what are their rights, what institutes are there, or even services are there to support them. So that's something we should try with the EuMGA to find out for all the different countries. So that's quite a work. Also to give that support to our members. Now we try to support them as much as we can with information, bringing them together, give them educational courses. But at the end, what we are striving to in Europe is that all patients have equal rights and equal conditions of care, at least in Europe. That's something that we are striving for. equity in the whole of Europe is one of the least things we can work to, alongside with as much as information that we can give. We also are a bridge between the European level, because a lot of us are lobbying, at least, and advocating at the European level, just to have to be sure that new treatments are at least easily recognized and confirmed in use at the European level. It's also a collaboration with EMA, what we are doing. So we are trying to do a lot. The journey of an MG patient is something which is not easy. And a lot of you will know that. A lot of you will have sorrow because you lost a lot, especially the young people. They are at the start of their career and they couldn't finish it. They are still searching and looking to find a way to try to live with it. And it's a struggle they have to go through daily. But at the end, we are together. We are quite a jolly bunch when we are together. So never pity us, just try to understand us. And that's sometimes the difficulty with doctors. They don't understand us. And I like when you say it's just more than the physical assessment. And that's true. It's more than that. And that's something that it was another Italian doctor that said there should be a change in mindset with the clinicians so that they do understand that it's more than physically burden, but also a mentally burden to live with it. So I think that's my journey as a patient with MG.
Thank you very much, Lutgarde and Lorenzo, for this webinar. There's no question now for you. If you have a question, don't hesitate to write it on the chat box.
I think we have been very clear.
Yes, I think so. It's just what I was gonna say. Okay, so I think we can close this session. Thank you very much for being with us today. See you next week for the second episode of the series. Don't hesitate to go in the website and to see the next series. Thank you very much.
Thank you.
Goodbye.
Goodbye.
Bye.
Thank you.
Bye bye, Lut.
Bye bye.
Bye bye.
Bye bye, Elizabeth. Thank you
Bye
for the
bye.
invitation.
Thank you. Bye.
Bye.